You are
Hi.
live.
Great. Thank you, Dr. Sergio, Dr. Deepak Megur, for being with me today. I always appreciate this time and the opportunity to be part of these amazing lectures. And today is a great pleasure and a true honor to welcome Dr. Deepak Megur from India to this masterclass. Dr. Megur is a highly respected ophthalmic surgeon with extensive experience in complex cataract surgery and glaucoma. And he has we have learned a lot of his surgical videos, lectures, and practical approach to challenging cases. And what makes his teaching particularly valuable is his ability to explain not only how to perform a surgical maneuver, but also why and when to use it. And today we have the privilege of learning directly from his experience, and we discuss two particularly challenging situations within the cataract surgery, which is hard cataracts and posterior capsule rupture, and how he managed his individual approach to this situation. So, Dr. Megur, thank you very much for joining us today. It is a really a pleasure to have you here. So, the masterclass is yours, Dr. Sergio. If you have any other comments before starting,
I
thank
want
you once
only
again.
to say thank you, Deepak. It's a pleasure for us. Your amazing challenge case that everybody know, and for us and our audience, it will be amazing to be with you today. And thank you again to accept our invitation, my friend.
Thank you, Sergio, and thank you, Dave, for having me. It's my pleasure. And the topic which we're discussing would be, probably managing difficulties which we encounter in hard cataracts. And I'll be covering a little bit of the posterior capsular tear diagnosis and management as well. So thank you for the opportunity, and let me start by sharing my screen here. So let's begin by the what can go wrong when you are dealing with a hard cataract. Okay, so the what are the challenges we have for a hard cataract? Okay, so all of us know that the corneal endothelium will take a hit. There would be corneal burr, and much more concern would be incidence of PC tear is significantly higher when dealing with a dense nucleus, especially with the beginner surgeons. So some of the common mistakes what the beginner surgeon would do and which they ignore when doing this is what I'd like to highlight. Okay, this is one of the cases. One of my junior colleagues is operating. Let me start by the case here. So this is a grade 5 nucleus. The surgeon, my younger colleague, is just around 300 or 400 phaco's old, and the surgeon is quite confident that she can go through this no problem at all. So what she has done is she's created a small central pit here, and that is ideal because you want to have a very good hold when you want to do a nucleus chop. So the plan is to go and bury the nucleus and then do the vertical chop. Let us see what happens here. So just observe here, the tip goes in. The burying seems to be all right, but the moment she does this, there's a torque. Okay, this is an ominous sign. When the nucleus of this density and this size, it moves like this, it is an ominous sign. So you had to take a pause, maybe think of some other technique. But when in that moment you would not understand all these finer nuances and the surgery is being continued. So the grip is not great. Look at the position of the handpiece, the phaco tip. It has gone way paracentral area. Okay, it has gone beyond our central safe zone here. Because now, at any cost, we would want to have a chop. That is the mentality of the surgeon at this stage now. So the chop is being attempted. Of course, we know that the lateral separation maneuver is going to be very stressful, but the plane at which you do lateral separation is going to be is important, critical. The right hand, if it goes down, the dominant hand, if it goes down while doing lateral separation, you are going to tug and pull at the posterior capsule. This is the stage at which you can damage the posterior capsule. So multiple attempts are being done, but just want to highlight one thing here. Look at the right hand. It has gone a little bit down, and subconsciously or without the knowledge of the surgeon, it is just pushing a little bit posteriorly. And these maneuvers are the one which are going to take a toll on the posterior capsule. The surgeon is still not aware. Surgeon is going on and trying to do the job. Okay, let us see what happens. One more job. Again, of course, you can't expect it to be separated in a single maneuver. You can see this always. And then look at this right hand. The surgeon would probably focusing only on the left hand, how the left hand is moving, trying to separate the CAC. In that, what happens, an inexperienced surgeon would not notice what is happening to the right hand. You can see it is going way behind, way behind. So our ultimate goal here is to somehow separate the nucleus, but we end up causing a lot of trauma to the posterior capsule. This is what happens here. So at this stage, you can clearly see this piece is slightly more posterior than this piece. This is also in the bag. This is also in the bag, but we can clearly see the difference in the plane. Now, this is the hint that the nucleus is, something is wrong now. You can't have the two different planes of a nuclear fragment which are still not separated totally. So this should alarm us that something is wrong. The surgeon is realizing this now, that something is wrong. You can clearly see that there are two distinct planes. The moment the phaco probe is out, you can see that the fragment came out, and the surgeon did realize that something is wrong, and she wanted to salvage it, just trying to pull it out, but eventually it was not successful. So what do you get here? We get the Titanic song here. The nucleus is sinking. So the best thing to do is just leave it, close it. Don't go in and search with your vectors or trying to hook it out. So if you're especially a beginner surgeon, just close this case and just refer it to the retinal surgeon. The retinal surgeon would ensure that the case would go well. So the first message here is, when you're doing chopping, you have to be very conscious about the maneuvering which you're doing. You have to be as gentle as possible, as miserly with your movements. You cannot have rough movements. Although the surgeon was quite delicate, but still, the first torque itself, we can show you if the first torque, let me go back and show you here. The first torque, when you go in, this can happen because of two things. You're not got a good grip, or the chopper, ideally you should use a much more sharper chopper. Your burying has to be sufficiently posterior. If you don't have that and you lose the grip, this is when you're going to get a torque. Let me just play that first scene here. Just I would want all of you to observe now. So the burying is all right. Again, it loses the grip. And look at the position of the right hand. It just keeps going away. So be conscious about this maneuver. I think the first torque was here. So this is one. Observe this. Okay. Now this movement is quite traumatic to the posterior capsule. If you're having this, immediately, convert to other technique, or just maybe abort phaco and maybe think of doing an SICS, which is very common in our country, or if you're comfortable with SICS, that's best. Otherwise, do an ECC. So similar situation, I'd just like to show you another such situation one more time here. So again, a dense cataract. You created a trench here. You want to go in and bury. And nucleus forward. And you can see the torque happening. This is something which is very common in these ultra hard cataracts. So I would recommend, be cautious, decide what technique of nucleotomy you would want to use. So my recommendation of late has been to go back and simply do the divide and conquer technique. Let me just show you that now. So is my screen visible now?
We can see your screen, but we're seeing the same video. I think you need just to change on share and share again your screen to see the other video as we did it previously.
Just see, is it the same? I think, is it the same video?
Yeah. The one with
You
the
can
top.
you can discuss the first one if the audience has any question, David, while you prepare the next video. What do you think, Deepak?
Yeah, no problem.
You have a question, I think, here. Let me see.
There is a question from the audience, I think. Yeah.
Yes.
The moment she realized something was wrong, how would you have proceeded at that moment?
Convert, abort phaco. Even of the first notice, whenever you see that the torque is there, something is wrong, I would recommend a beginner surgeon to just abort the surgery, because what happens in an opaque nucleus, we don't know, we can't see the posterior capsule. We can't see the posterior capsule. So just convert to your manual SICS incision. If you're sitting temporal and doing, usually we recommend doing temporal phaco. If you're doing temporal, switch the superior quadrant, create a fresh sclerocorneal tunnel, pull the nucleus out manually, and then see, rather than continuing. That would be my recommendation.
Great.
Okay. Uh, Professor Deepak, when you have the next video, you can share.
I'm
I think
ready.
ready?
Yeah.
Okay. Eric, please.
So I just showed you what would be the right, what is the not the right way. So I would recommend most people who are doing the dense cataracts to follow the divide and conquer or the four quadrant technique. I believe it is very, very, doesn't cause any stress on your posterior capsules, zonules, and because we have coded the most dense part of the nucleus, the lateral separation becomes much more stress free for the bag and the posterior capsule. So just let me take you through one such situation. This is again a grade 5 nucleus, okay? So here I'm using 90% torsional ultrasound. This is the Alcon Legion machine, or the Centurion Silver, you can say. So what I just want to just draw your attention, just I enlarge the groove a little bit, widen the groove a little bit so that it can give access to me to go deeper. The secret in dense cataracts, you need to sculpt very deep, 90% depth. And in the course of the video, I'll just show you how to identify the right depth also. So just widen it just a bit so that my tip goes in. And now if you observe, the tip is exposed a little bit longer than usually what we do. This gives me access to go in much more deeper. You can just core through the nucleus much more deeper, reach the most posterior part of the nucleus in a very traumatic way. So when you're doing this sculpting, the nucleus should not be shooed around, should not be pushed. It should just be the ultrasound energy which is just shaving across. It should be effortless. So we would want to have a slightly bigger, longer trench as well. So having a larger rexus does help. Now this rexus is about 5.5 millimeter. Look at it. The energy should cut through the nucleus, not any mechanical force. Common mistake what people do is they would be pushing the nucleus mechanically. That would take a toll on the zonules. So effortlessly keep just trenching it. That would take care. The once you reach the more deeper part, you need to probably increase your energy delivery a little bit. And here I would like to draw your attention to one important point here. You can see these transverse striations. This is what we call as the transverse lenticular striations. These are a representative of the lens fibers which form the core of the nucleus. The moment they become less prominent or they fade away, that is when your entire endonucleus is ending. And that should be the end point for us to stop and then do the lateral separation. So I'm just continuing to do the lateral separate, to do the coring of the nucleus. And it has to be as gentle, as controlled as possible. And in the first part, always I'd recommend 50% of the mouth of the tip should be open so that we don't have an occlusion here. And what would be the setting? 90% power. The flow rate is important. It is very less. It is just about 14 or 16, and the vacuum is about 80 to 100. You can see these are the striations which I was referring to. You can see these transverse lenticular striations. These are the striations say that okay, we need to still go deeper. That's what it indicates. So I'm just going in and doing this. So very controlled manner. There is no hurry. You got all the time in the world. The key here is to reach to the most posterior aspect of your the posterior plate. Then you are going to have a easier separation. You can see that these striations are still present; they're still not faded away completely. I'm just trying to go in as deep as possible. When you look down through the microscope, sometimes it's very scary. You're going too deep. Okay, invariably our sculpting would not be deep enough than what we would want, actually speaking. But that is how it is. That's the secret here. So I'm just continuing to sculpt until these transverse lenticular striations give way, and there's a small change in the color of the plate. The moment it turns a little bit darker, I would maybe stop and maybe consider doing the lateral separation maneuver. Remember, in these brown cataracts, you don't expect to see the appearance of a faint red glow, which is the classical way of identifying the depth of the trench. That's not going to happen here. So we need to assess some other signs here. And these are very bulky. The lens thickness would be anywhere 4.5 millimeter or 5 millimeter with the thickness of these lenses. So that is the trick. So I'm just continuing to trench. And the striations at some time become a little bit fading. Okay, this is how the difference would be. This is now the striations are there, but still not they're still not gone totally. But I am attempting a lateral separation. The instrument which you're going to use, the second hand, should be having a slightly longer than what I'm using now, because you can reach the posterior plate much more easier. So it is not going to crack in a single moment, and we are going to make multiple lateral separation maneuvers. So now let me pause again here. This part of the posterior plate is cracked, but you know what? The central small 1 millimeter hinge or maybe 0.5 millimeter hinge is still attached here, and this is probably the thickest part of the posterior plate. It is not cracking, but nevertheless you can't stress too long, because you need to be mindful that when you do an excessive lateral separation, you are going to stress the rhexis margin as well. So you need to be very careful in the way you do it. A longer instrument would definitely help. You could go back and place it much more deeper, and then it would have been much more easier. So this appears to be slightly better. Okay. So now there is one more fragment which is to be left. You know, when you're doing this, the maneuvers are very controlled. There is no rush. There is no undue stress being put. And now what happened? You have got 4 fragments, but out of this, only one fragment is well and truly divided. So what I do, I just gently push it away so that the base is turned up towards me. I pick it up with my phaco probe and then pull it out. Okay. Now, emulsifying the fragment obviously is going to be very easy. It's not going to be difficult at all. I refill the chamber, and now we have a problem. 3 fragments are separated in all around except the central bridge. There's a central bridge which is still holding them. When you try to do a lateral separation, go back and try at this stage, at this plane, in the posterior plane, the risk is high of causing a posticapsular tear. So my solution for this recommendation here would be, I would do this maneuver after filling the bag with OVD with the Sinskuk. Just bring this plate more anteriorly, which is what I call as the flip the base up and then phaco. You know, you just flipping this part, you bring this bridge which is holding these 3 fragments anteriorly. You can see that these 3 fragments are attached, but the small bridge has been pushed anteriorly. You go in and put back OVD. The bridge is now, which is connecting this, is direct visualization. You just take your phaco, go back in your sculpt setting, and then give a short burst of phaco, you destroy it. The bridge is destroyed. So you don't have to do any mechanical struggling to separate them. All the 3 fragments are separated. You push them back into their place in the bag, and then pull them one by one, and then emulsify. So this is a very safe way to break the posterior plate if you don't have a complete separation of all the fragments. Remember, after each fragment, it is almost customary or religious for me to go back and refill the chamber with OVD. So usually I would refill first with dispersive OVD, the viscoat or viscoat-like substance. And underneath, I would use HPMC, hydroxypropyl methyl cellulose, because it is less heat generating. it's important that we follow this religion, because the endothelial damage usually happens because of the mechanical trauma of these hard fragments. So if you keep filling the chamber adequately and timely with OVD, you'll be surprised how good the cornea would be. So this is the major part of the surgery is done, and these are the cornea would look like. You'd be surprised that how clear the cornea would be, provided you take all the precautions. Of course, I was lucky that the patient's uh, endothelial cell function was quite good, but this is not a surprise. If you very carefully can do this. So technique which I would recommend here would be when these posterior plate is hinged or attached at one area, somehow try to bring out one piece of the nucleus out. When you create this, there is space within the bag. Then with OVD, you can just go fill in and bring this joint which is there at the posterior capsule, flip it up, and then you have got direct access to it. And this is how it is. You're going to remove one fragment out of the bag. This one fragment is out, and you can see these three fragments are attached. Fill the bag with OVD, and then you're going to use a viscocannula itself to flip it up, or you can use a Sins cube to just flip it up. And now what happens? This attachment is, this is how it is. I'm just using a Sins cube just to pull this bridge anteriorly. Now what happens? Now this bridge which is holding all the fragments is directly accessible. Just give a small burst of phaco and it's all done. That's it. So you don't have to do any mechanical struggling. So this is what you should do when you're doing your hard cataract. I think that would be the message with this presentation. And if you have any questions on this, we can take, or I'll go to the next case.
I think it's amazing. It's a really good tip. I have one question about this before we move into the next video. You say that when you're, creating the groove in Divide and Conquer, I see in your videos that it looks very smooth, like butter. Can just we repeat the parameters that you're using here in ultrasound power to reach this stable movement into the back?
Yeah. See, I think the most common error which people do is they use a very high flow rate and high vacuum while doing sculpting. That's the reason why when you go, you're going to catch up the end of the trench and make a hole there. Secret here is have a very low flow rate and low vacuum. That's the secret. Okay, so when you have low flow rate, you can just cut across in a very controlled manner. You can make a very long trench as well without the fear of catching the equator and causing a hole there. The only parameter which is going to change is the power. The power is going to be dependent on the density of the nucleus. If you have a very soft nucleus, start from 30. If a very dense nucleus like this one, start with 80 or 90 or whatever it is. So this is the secret. The secret is low flow rate and low vacuum. The flow and vacuum do not have any function in sculpting. They have a function in chopping and quadrant removal. This concept has to be understood by the surgeons. So usually the machine person will come and keep it whatever factory settings. They wouldn't change it also. They would same thing. And they said it would jump. The nucleus would jump in its trenching. So these are things. So if you have a low flow rate and vacuum, it cuts like butter. Only parameter is going to change is the power, which is based on the density of the nucleus.
Great. Yeah, because sometimes you push the nucleus when you're trying to form the trench, and that's kind of tricky because you're pushing downwards all the back.
Yeah. No, you shouldn't push downward. It's always angulated. There's no posterior. As I told you, when you're sculpting, remember that this is the whole of the phaco tip. Half of the tip has to be open always. If you keep this in mind, then what happens? You will not go posteriorly. You can always go like this in an angulation. Okay.
Professor Deepak, there is a question from the audience.
On flipping the hinge, the edge of nucleus is not rough on posterior capsule? Is a question.
Yeah. No, it wouldn't be. When you flip it up, the edge is actually coming anteriorly. What goes behind is the back surface of the lens. So it won't damage the posterior capsule.
And the next one is...
How low is the flow and the vacuum when you're doing the groove?
For sculpting, I would recommend a flow rate of 14 to 18. And vacuum should be anywhere between 80 to 120.
Professor, how you do with your residents in your learning curve? You start with divide and conquer, and after you go to stop and shop, and after to fake or shop. How is your learning curve for your colleagues that study with you?
Yeah, I would recommend, or that is the protocol which we follow for our trainees is first do a divide and conquer 4 quadrant technique, then stop and chop, and then do the direct chop. But most younger colleagues of mine are so fascinated by direct chop. It is so glamorous for them. The first question they come and ask, I want to do direct chop. I want to do direct chop. I'll tell you a small story. Even when I was learning, I was also glamour struck by the direct chop. I learned my direct chop first, but it took a long time for me. The learning curve becomes very long if you start with direct chop as your first way of dividing the nucleus. It's my personal experience. And then after my learning curve was long simply because of that. Because in conferences when we went and saw everybody is doing direct chop, so I thought it should be damn easy, man. So I went, and it is difficult for most people because the control of the left hand or the non-dominant hand, it takes a while for you to get adjusted to it. So the mind has to read the sound, the foot control, and both the hands simultaneously moving. So it takes a little bit of a while. So recommendation for people who are just starting off: start with divide and conquer, then stop and chop, and then eventually we all do direct chop now. Most of us, because we find it's laborious to do the divide and conquer. But still, for these hard cataracts, I'm going back to divide and conquer. I'm still doing 4 quadrant technique for these dense cataracts.
Okay, next video, David.
Yeah, yeah. Let's move to the next one.
David
Let
is
me
the
see.
boss today, Professor.
No, you're always the boss, Dr. Sergio. I'm just helping here. Whenever you're ready, Dr. Deepak
Yeah,
Megur.
I'm just doing this.
Great.
Okay.
And folks, if you have more questions from the audience, send us. For us, it's always a
So,
pleasure.
yeah. So for all the trainee surgeons who are there, the common question is, PC tear, posterior capsule tear is probably the most dreaded complication we all fear, and I'm sure every surgeon's worst complication they would imagine. But let's try to understand how the morphology of the posterior capsule tear looks like. Now, because we have the advantage of a stereocoaxial illumination in most microscopes today, the understanding of the posterior capsule tear should differ and help us understand a little bit more. Because this would help us to identify the PC tear much more earlier, and that would help us to prevent the vitreous prolapse. Let us see how does it look like. So I call this morphology. How does a posterior capsule tear actually look like? Okay. So let's try to understand. So when we see there is a breach in the posterior capsule, I hope it's clearly seen. There is a breach in the posterior. There is a continuity. The PC is lost. So what we see actually, you can see there will be two lines. Okay. You can have two lines or you can have one line. Whenever you see there is a line in the posterior capsule, or it appears like this. So, many times we can see these two lines together, and sometimes we can see only one line. So these are basically the margins of a posterior capsular tear. Rarely you may get confused with the posterior capsular fold as well. Whenever you have a lax posterior zonules, you may get posterior posterior capsular trampolining. You may get a posterior capsular fold. But if the line doesn't change its position, it's always there, it doesn't disappear, it's a permanent thing, then this line usually indicates a posterior capsular tear. You can have two lines like this, or you can have a single line because the other edge of the posterior capsular tear is not visible. So basically, you can say that one or two lines. Yeah, this is what delineates the margins of the posterior capsular tear. Because we have excellent red glow nowadays, we can see that a single line does not rule out a posterior capsular tear. A single line here is just a single line. We don't see the other edge because the other edge is somewhere gone beyond. Okay, so it is in the beyond the pupil. The posterior capsular tear, of course, comes in different sizes and shapes. It can be very tiny like this, or it can be very massive. depending upon how early we are diagnosed or how late we are diagnosed, and each of them has a definite shape and a morphology. So next question, does the PC tear mean vitreous prolapse always? Okay, that's another question we need to answer now. No, it does not mean. So that is what we need to train our eyes to identify just by looking at the posterior capsular tear, what is there. Now, when we look at this posterior capsular tear, it has got two distinct edges, but they're not splayed wide apart. Okay, when they're not splayed wide apart, you can fairly conclude that this is posterior capsular tear isolated. It does not involve anterior haloid rupture. That's what it indicates. So when you look at the margin of the posterior capsular tear, it tells a story. So can we differentiate a posterior capsular tear with vitreous disturbance and without with vitreous disturbance? So let's try to understand then. How do we differentiate that? Well, it's possible to differentiate. Just look at the posterior capsular tear without prolapse. So if there is no prolapse, the number one feature would be the posterior capsular tear defect is much more narrower. You can see they're not splayed wide open. They're very much nearer to each other. So you can see these are some of the classical PC tears which you see in posterior polar cataracts. And this is a round one. And when you see a round posterior capsule or a vertical one, either way, when you don't see kinking of the margins, the edges are very well defined and they're regular. There is no kinking of the lid. Kinking in the sense there's no distortion of the margin. Now this is a circle which is perfectly circle only. If there was vitreous, it would have dragged one edge and maybe caused irregularity on it. We'll come to this. Now this are the second sign. Third sign is if at all you see the flap of the posterior capsular tear, and if it is freely fluttering, it is just waving with the fluid which is happening there, that indicates that the tear is not there. You can see this again, the edge is fluttering here. The edges are not widely splayed. There is a narrow gap between them, two of them. And this is we can fairly conclude that the posterior capsular tear is there, but the anterior haloid is still intact. Now, how does a PC tear with vitreous prolapse would look like? So these are some of the common features. The edges would be very wide. The edges of the tear would be very wide. Look at this. It's an extremely big posterior capsular tear. The edges are widely splayed. And then you can another case of a wide posterior capsular tear. And then most importantly, there is a deformation of the posterior capsular tear. Can you look at it? There is a kink here. Whenever you have the margin which is distorted, this is because the vitreous fibril is running across and dragging that margin there. So, and these edges will not be fluttering because the heavy vitreous would be coating on it, and that's the reason why you won't have a free fluttering of the edges. So if you just carefully just observe, this is what we call as a double ring sign. In fact, many cases we can see, if you're very keen and early to pick up, we can see two rings. The first ring is of the posterior capsular tear. The second ring here would be an anterior hyaloid rupture ring. You can see there's a faint ring which is here. This is the moment in which the anterior hyaloid has ruptured, but the vitreous prolapse has still not come out. The moment it comes out, you lose the ring. So, this is the thing, and I was not sure. This was one of my first observations. I go in and put in OVD. The moment you put in OVD, the vitreous is pushed out, and you can suddenly see the second ring disappears, and you can see the kink or irregularity of the margin appearing here. So look at it here. Now, this is a stage in which the anterior was just ruptured, no vitreous prolapse, but this is what we call as a double ring sign. And the moment vitreous comes out, you can see a distortion of it. Again, it's another case, a PC tear, and actually we can see this anterior hyaloid ring which is ruptured. This is a stage where we have lost it. The anterior hyaloid is ruptured now. Another case, I'm just trying to do some hydropolish. The patient just moves an eye, and this has escaped my attention. I continue to irrigate. The capsule tears enlarges, and there is a second ring which appears. The second ring is the anterior hyaloid rupture. So what does this teach us? PC tear and anterior hyaloid rupture are two independent entities. Okay, because it gives me a few second time. If I diagnose it earlier, the second ring formation would have been prevented. So that was the message from this video. And how to identify the how to read the posterior capsular tear. So maybe before taking the case, I would like to finish another video how to suspect a posterior capsular tear with an overlying nucleus. Okay, then maybe we can take the discussion.
Yes,
Great.
you have some questions from the
Okay, no
audience here.
problem. Okay.
When do you decide to do anterior vitrectomy after posterior capsule rupture and vitreous phase disruption?
No, if the anterior hyaloid face is ruptured and vitreous is prolapsed, you have to do vitrectomy. There is nothing like you can't get away with that. If the anterior hyaloid is breached, then you have to do vitrectomy. There is no second thought. Only in the situation where the anterior hyaloid is intact, you can go ahead and place the lens inside without doing a vitrectomy. That's the idea of identifying this. So, of course, at the end, you can always confirm with doing a staining with triamcinolone. But even looking at the posterior capsular tear morphology, you can be fairly conclusive that you know whether the vitreous is present or not. That is the message. The vitreous has come out, then you have to do vitrectomy. There's no second thought about it.
And from Dr. Leilei, do you remember great Dr. Leilei from
Yeah.
Myanmar? Davi?
Yeah, I remember her.
Hello,
What,
Leilei.
hi Lele. What are your selection criteria between extracapsular cataract extraction and phaco when I guess that this question is, sensing brunescent or very dense
Okay.
cataracts.
Yeah, in our country, we usually don't do ECC nowadays. We're doing just SICS. But anyway, the question would be same. A situation where the endothelial cell is very compromised, the apart from the complexity of the nucleus itself, endothelial cell health is important. And if the zonules are not great and elderly patient, you've got a thick arcus, visualization is going to be a problem. These are some of the situations where I would go ahead and do the non-phaco technique, if I may say so.
Great.
Okay, next video. Deepak, if you want to go to the next video, I think you don't have more questions. Oh, the last one.
Yeah, video, I'm ready with the video. So I think this has got some audio here, and let us see.
And this is a mature white cataract with a hard nucleus. The last two pieces are to be emulsified. There's a faint line visible posterior to the fragment, and this was suspicious. Now I'm left with just the last piece, but the underlying PC tear is staring at me. In my head, I'm thinking I can emulsify this nucleus and there's no need to come out. At the same time, I'm trying to understand the morphology of the tear. The edge of the tear on my left seems to be having irregular edges, while the right edge has a straight border. But both the ends of the tear look to have extended up to the equator. At this stage, I'm not sure whether the anterior vitreous phase is intact or not. Now, looking at the irregular edge of the PC tear on the left, I thought maybe the anterior is still intact, but the real action happens now. So please don't blink. So did you see? It was like a bomb blast, except for the sound. So let me replay it. The phaco end piece comes out and the AC shallows. Now, as the AC shallows, we can see a ring appearing. Now, this is the anti-haloid rupture happening and the vitreous collapsing out. This was a costly mistake. If I had not allowed the antechamber to shallow and if I had injected dispersive OD before coming out, the anterior hyaloid rupture and the vitreous prolapse could have been prevented. I assumed that the anterior hyaloid was ruptured looking at the configuration of the left margin of the posterior capsular tear, which was incorrect. The rule of not allowing the chamber to shallow while withdrawing the infusion should always be followed. It is sacrosanct. So the moral of the story, the secret is in the chamber.
So never allow the chamber to shallow, okay, whenever you have a posterior capsular tear. So you could have prevented an anterior rupture if I was swift enough and I don't allow the chamber to shallow. So let me just go back and share another video now.
Yes. Eric, next video.
Yeah, I'm
Next
ready.
video. Yes.
Okay, so this is
Okay, let me take.
how do we diagnose a posterior capsular tear when the nucleus is still there? That is the we. I explain now how do you diagnose PC tear? How does it look like in the presence of a beautiful red glow? Now, when there's an overlying nucleus, how do we suspect the underlying PC tear? Just I'll take
Let me
you
take
through
you
few
through few
clips.
cases. A middle-aged lady with a white cataract. As the intracameral anesthetic is being pushed in, there's a momentary deepening of the chamber and we see a pupil snap sign. Mind you, we are seeing at a stage where anterior capsule is not even touched. Well, it's easier to appreciate this phenomenon on a video review with multiple rewinds, but it can be easily missed during a live surgical event as it happens so sudden and transient. In this case, the sudden deepening of the antechamber was indicative of the occurrence of a posterior capsule tear, which was seen only when the nucleus was removed. And this was a case with a possible weak posterior capsule, maybe a case of a polar cataract. Another case of a white mature cataract. As the OVD was being injected into the antechamber, there is a momentary feel of snap. The antechamber suddenly deepens. These changes are so momentary that one can miss them if we blink during the shot. My worst fear of an underlying posterior capsular tear was confirmed subsequently, and the case was salvaged by converting it to manual SICS. Now, this is the third case of the emulsification being performed. There's a momentary fluctuation in the antechamber. This sign alone should warrant us about the possibility of an underlying posterior capsular tear. Fake.
So the message here is whenever you see there is an some change in the chamber dynamic when you're doing fake emulsification, so that should really caution us something is wrong because we're not able to see the posterior capsular tear directly. So this situation we have to be alert and maybe consider converting to other form of surgery. That should be the message. So observe the chamber. Whenever you see sudden chamber fluctuation, a pupil snap sign, be very alert to identifying this, and always err on the side of the PC tear. You could be having a PC tear. Just convert, and you can prevent a nucleus drop. Most nucleus drops are happening because these subtle signs are not picked up in the initial stages. So I have, if there is time, I'll do another video on vitrectomy. Otherwise, we can have
You have
discussion.
time. You have time. You want, my friend. Well, for us, a pleasure.
Okay. So I'll be showing now a last video now, and then we can. The title would be "How to Prevent Enlargement of the Posterior Capsular Tear when doing antivitrectomy." So, okay, I think my share is being seen. So we all know that the past plan approach is the most popular one. Dr. Vasavda has really taught us like how to do what is the relevance and importance of performing a past plan approach for doing antivitrectomy during a PC tear. The idea is the chances of the posterior capsular tear enlargement are lesser when we do pars plana because you're trying to pull the vitreous from behind. That's the reason why it doesn't enlarge. And that's the reason why the recommendation in the current times is like that. So my question was, can we achieve similar results with the limbal route as well? And if so, how do we do that? So I just like to take you through my few experiences and my practices. So this is my goal. Can we achieve similarly by doing the limbal approach? The reason is many of us are not so comfortable with the pars plana. Many of the cataract surgeons and doing a pars plana incision in a very soft eye can be tricky for a few of the surgeons. So if we are able to achieve similar results by doing a limbal approach, well be it. Well, obviously there is no debate that the pars plana approach definitely is much better in controlling the enlargement of the posterior capsular tear. So let me take you through few cases now. Okay? The first principle obviously is, I told you in the previous video, when you suspect a posterior capsular tear, don't come out. You have to inject OVD, keep the chamber stable. That is the secret. You have to keep the chamber secret when the chamber stable when you come out, because if the AC shallows, the posterior capsular tear comes forward and it enlarges, and then more vitreous would prolapse out. First thing is, before coming out, inject OVD into the eye to maintain the chamber. Don't overdo it also. Another important point is, don't overfill. Just enough to maintain the chamber as you come out. Inject OVD and then stop the irrigation and then come out. The next important thing would be to decrease the infusion pressure. Remember, this is not highlighted much. So whenever you have a posterior capsular tear and you're considering doing an anterior vitrectomy, first watch the bottle height. You have to decrease the bottle height. Infuse, because the eye already has a OVD, and then if you go in with a bottle height of 90 centimeters, it is going to blow open the posterior capsule. The most common reason for enlargement of the posterior capsule is high infusion pressure, because most surgeons are not mindful of this. They'll be stressful, and when doing cortex aspiration, the PC tear has happened, vitreous has come out, bottle height is 90 centimeters. Even while doing vitrectomy, they go with the same infusion height. No, because what happens is, there is a direct communication between the anterior chamber and the vitreous cavity. And the vitreous cavity is a huge well. The fluid has direct access to the vitreous cavity, and then you have more vitreous just collapsing out. So mind you, this is probably the most important principle to remember. Just decrease the infusion pressure as you begin the vitrectomy. Because again, but suddenly when you go with so much pressure, it just opens up the posterior capsule. Look here what happens left side. You can see suddenly the posterior capsule opens up, and you can enlarge the posterior capsular tear with just this one maneuver. The second is, when doing vitrectomy, this is what I call as the segmenting the prolapsed vitreous into two parts. Now, this is achieved by following certain principles, by placing the vitrector at the right plane with its port oriented in right way. Basically, we're trying to divide the prolapsed vitreous into two parts, one which is in the vitreous cavity and then which is prolapsed out. So once we have cut out this adhesion between them, then we can take care of the anterior part, and this helps us to prevent the enlargement of the PC tear. So how do we achieve this? The posterior capsule, this is the PC tear. The cutter is placed behind or at the level of the posterior capsule tear, with its bevel down first, the port. You have a low irrigation bottle height, then you begin cutting. Just continue the cutting with the highest possible cut rate. Be stationary, don't move at all. And once, after some time, you realize that you've done some vitrectomy around here, and the prolapsed vitreous and the vitreous which is there behind the posterior capsule now is separated. Then you are turning the port sideways and doing continuing vitrectomy, and then anteriorly, and then you are pulling back the vitreous which is prolapsed out. And this step ensures that you're not tugging or pulling at the vitreous or the posterior capsular tear. That is how you can prevent the posterior capsular tear enlargement. Now, it's the same case which I was showing you before, where we had a posterior capsular tear and we have an anti-hyaloid rupture. And the moment I put in OVD, the vitreous just collapses out. The moment I put in, the vitreous. Now you can see this edge is, there is every possibility that this edge can extend out. So my goal is to ensure that this tear does not go up and I can place the lens in the bag. That is the idea. So how do I do a vitrectomy at this stage without enlarging the posterior capsular tear? You can see these edges are irregular, so they can still go ahead and enlarge. So first what we do is, always if there is any vitreous at the wound, first cut the vitreous. Now first cut the vitreous before entering inside. Now usually this chamber is now maintained with OVD itself. Now I go in with the cutter. Whatever vitreous is just in this area is just cut out, and then the cutting is stopped. And then after doing some cutting, then the irrigation is introduced, because at that time you saw the bottle height was just kept 20 centimeters. Now look at the position or the port angle. The port is facing posteriorly. Now it is placed behind the level of the posterior capsular tear, behind the level of the posterior capsular tear, and then the cutting is started now. So you continue cutting until you realize that the vitreous which is around the posterior capsule is taken care of. And then you turn the bevel sideways and then anteriorly to take out the prolapsed vitreous anteriorly. So at all these stages, the bottle height was kept low. But now when the vitreous is cleared off, the chamber starts to flutter. That's the time when you want to increase the bottle height. So that's probably indicative of the end point as well. And once you're sure of that part, and this is how the posterior capsular tear looks like before doing vitrectomy and after doing vitrectomy. It is almost the same size. Now, before putting the lens, it's important that you take care of this posterior capsule. If the visualization is great, make it into a round rexus and then put in a lens, simply because while putting the lens also it can enlarge. So the message here is, if you follow the right principles, you can prevent the enlargement of the posterior capsular tear. So what are the principles? First, never allow the chamber to shallow. Put in OVD before starting decrease the infusion before starting vitrectomy. And third would be to do the vitrectomy following the right principles. So high infusion pressure has to be minimized. This is what is the most common culprit why the posterior capsular tear enlarges. And then would be, how do you segment the vitreous? This is how what I'm practicing, and this has worked well for me. Start with the vitrector paste just posterior to the posterior capsule with the bevel down. Do the vitrectomy around this area, and once it is done, you turn the bevel sideways and then deal with the anteriorly prolapsed vitreous. By doing so, you're not going to pull out more vitreous. In that process, you're not going to enlarge the posterior capsular tear. So another situation is, if there is an opportunity for us to do a posterior capsular rexus whenever you have a posterior capsular tear, and at this stage, if the vitreous has not still prolapsed out, or you can push it back with OVD, performing a posterior capsular rexus at this stage is much more easier and much more helpful for us to prevent the enlargement of the PC tear than doing after vitrectomy. Now, once the PCC is done, if you do vitrectomy, it's almost impossible for the posterior capsular tear to enlarge. And this ensures that we can place the lens very much in the bag. So this is how it is. Now, this is a rigid lens which is being placed here. This is a case of a manual small incision cataract surgery being done. You could place the lens in the bag. So the take-home message: how to prevent PC tear enlargement during limbal vitrectomy. Number one, never allow the chamber to shallow, low infusion pressure. And third would be, use the right technique to do the antivitrectomy. My principle is to position it much more posterior to the posterior capsule and then segment the vitreous into two parts. Then we can definitely prevent the posterior capsular tear enlargement. And PCC definitely does help us in preventing the enlargement. Whenever there is an opportunity, whenever free edge, always do a PCC. Timing is critical. It's always better to do it before doing vitrectomy if possible. It's not always possible, because it is easier to do it when there is vitreous and supporting it posteriorly, because when the eye becomes very soft, it becomes a little bit of a challenging to perform the PCC. I think with that message, I'd just like to conclude my presentation. Thank you so much.
Amazing. Thank you very much, Dr. Deepak Megur. It was really good. I just have one question about this anterior vitrectomy. I have seen some surgeons that request my help when these complications happened, and the first question that they ask me, and I don't really know how to answer them because it's more how you feel during the procedure, but how much of the vitreous you do the vitrectomy, how much vitrectomy you have to do. Because I have seen some other surgeons that do a lot of vitrectomy because they are not sure if already, especially when the posterior capsule is not so small, when you have a complete rupture of the posterior capsule and you don't have these kind of tips to identify if it's enough. So they do a lot of vitrectomy, and then at the end of the surgery, the eye is very soft and very hypotonic. So this is also not so good. So when you see a completely blown out of the posterior capsule and you need to start the vitrectomy, how much vitrectomy you advise to do? What's your feeling during the surgery to say enough is enough?
Yeah, see, the goal of performing an antivitrectomy in the presence of a posterior capsular rupture is just to remove the prolapsed antivitreous, and just enough vitreous which should not come back and dislodge the posterior capsule. Our goal is not to do a complete vitrectomy at all. Vitreous is essential. It has to be there. just enough, just enough to ensure that the intraocular lens placement is not going to be disturbed in the future. Whatever is come into the antechamber has to be taken care of, and also a little bit below the posterior capsule, just enough, so that because what happens if you're not done enough vitrectomy, or if the vitreous is still hanging around at the edges of the posterior capsule tear, it can prolapse out later, or even when during the putting the lens inside. Having said that, important question is, what is the end point of doing vitrectomy? Okay, how much vitreous should I remove? It is very, I told you only little. How much? The end point is determined by one indicator. So when you start vitrectomy, the chamber is comprising of OVD and there is a BSS. And once you start doing vitrectomy, the vitreous is cleared off, OVD also gets cleared off, and then once the gel elements get cleared off, the eye starts to flutter, the antechamber starts to flutter. That is an indirect evidence. With the same bottle height, with the same infusion pressure when you started, the chamber is very well formed. But as you started doing, once the OVD is gone, once the vitreous is gone, the chamber starts to flutter. There is some amount of shallowing. You see corneal folds appearing. That is an indication that you are nearing the end point. You raise the bottle height, do a little bit more, and now you look at the margins of the posterior capsular tear. The posterior capsular tear edges will be fluttering. Once the vitreous is not there, the margins will start to flutter like this. When you see this, you're very clear that vitreous is not hovering around anywhere. That's it for us to stop. Two
Great.
guidelines. Once the immobile posterior capsular tear becomes mobile now. It was immobile before because the vitreous was coating it, and once it starts to flutter freely because it's mobile, there is no vitreous now. Second, you start with the same settings of flow rate, vacuum, and infusion pressure. The eye starts to dimple down a bit. It becomes, the chamber starts to shallow. You're forced to increase the infusion. That is the time you have to say, stop, it's enough. And of course, when you, before closing, I would still recommend always to go in, you put the lens inside, either in sulcus or bag, depending. Always put in a little bit of triamcinolone acetate, because missing out a single strand of vitreous is very, very possible. Because when the pupil is very well dilated, some single strand of vitreous can sneak in, and in the next day you will be surprised that the pupil is peaked because some vitreous strand is sticking. So always at the end point, you can always go in and put in a little bit of triamcinolone acetate, or 1 or 2.1 or 0.2 ml pilocarpine to just bring it down. So that ensures that you're not missing on that one single strand. You know what? The single strand is quite difficult to manage. It's easily missed. The bulk of the vitreous can be cleared, but somehow at the one edge you'll be missing. Next day you'll be shocked to see the pupil peeking there. So don't
Yeah.
forget to check for this element before closing it.
Yeah. Thank you very much.
Professor Deepak, you have some questions from the audience. The next one.
It says, what do you recommend to first go bevel down and then turn to bevel up? What is the problem if we do all the vitrectomy with bevel up?
Yeah, when you turn the bevel up, what happens is you're trying to deal with the vitreous which are anteriorly placed. You're trying to do it. That also can work provided if you are using the bevel posterior to the posterior capsular tear. It can still work. But my principle here is first to cut off the vitreous which is at the plane of the posterior capsule. That is what I would want to segment it. That's the reason I would prefer to do it like this. If you want to go with bevel up, fine. That also is all right. But don't start it at the anterior chamber itself. Place it a little bit more posterior, at the level of the posterior capsular tear, and then do it.
Next one.
The size of the infusion cannula to use 20 gauge.
This is the regular one which we use for our bimanual irrigation aspiration. It is 22 gauge. Mine is 22 gauge.
And the last one.
It says, before doing the posterior rhexis, you also fill the back with OBD.
Yeah, you need to do that.
Okay. And of course, the lecture, amazing lecture like this one will be available on the masterclass lectures. If you remember, everybody that stay with us in the Cataract Masterclass program can see all the masterclass. There is a lot of masterclass with really international speakers like Dr. Deepak Megur. It's amazing lectures that you can watch. Okay, Davi, do you want to do any final comments? Deepak, do you want to comment? For me,
Yeah, I would like to share with Dr. Deepak Megur one last thought, maybe. When we have a posterior capsular rupture and we have dropped nucleus into the vitreous cavity, there's always a question for some colleagues: do I need to implant the IOL in the sulcus? Do I need to leave the eye phakic and then implant in a second time the lens? I always answer this: it depends in the size of the fragment that goes into the vitreous cavity. But I usually recommend that if there is a bruness and cataract or a very hard nucleus part in the vitreous cavity, I always advise to not put the lens into the back. To leave the eye aphakic, maybe to arrange all the anterior chamber and clean all the vitreous as possible, but then wait for a second surgery or the vitrectomy to put the IOL, because it will hampers a lot for us as a retina specialist to do a phaco-fragmentation in the vitreous cavity. It's easier sometimes just to elevate the nucleus part and just remove it from the anterior chamber. So what are your thoughts in these scenarios? Because sometimes it's complicated when we receive a referral with a huge nucleus in the vitreous cavity and there is already an IOL into the anterior chamber. So it complicates a lot the things.
No, I think every cataract surgeon should have a very good vitreoretinal friend and always know what he would like to prefer. Some surgeons would prefer that you put the lens and send, but the standard guidance would be if you have the brunescent nucleus like the one which we showed, then it would be very very difficult to eat with the fragmentome as well. So PFCL has to be used and floating it up and then removed. Smaller fragments or entire nucleus which is soft, maybe just two grade 2 nucleus sclerosis, that is okay. You can still go ahead and place the lens. But anything grade 4 and above, I think it would be better to just leave it just like that and do the retinal surgeon the job.
Great. Thank you. So, Dr. Deepak, what an incredible surgical videos and what an outstanding quality of explanation. I really enjoy it. It is truly fascinating to understand in this way your surgeries in such a depth and learn from your experience. So thank you so much for your time, your generosity, your consideration. It has been a real privilege for me, and I'm sure for everyone in the audience, to learn from you and to see these remarkable cases. And again, thank you very much, Dr. Sergio Canabrava, for organizing and be the door to open all these master classes for everyone. Thank you very much.
Deepak, thank you, my friend. It's a pleasure again to have you here.
Thank you, Sergio. Thank you, Dave, and all of you, the entire team. It was a pleasure interacting with you all. God bless you.
Thank you.
Thank you
Eric,
very
can
much.
you
You
share?
too.
I'd like to, Davi, if you can stay a few minutes just to
Yes, of
invite
course.
the colleagues for, guys, next Thursday, 7:30 p.m. Brazil time is an event that is Portuguese and the international speakers will be in English, but for everybody in Latin America can watch because understand the Portuguese, the Portuñol, right, David?
The Portuñol, yeah.
Portuñol. And amazing, this largest biometry event that ever happened. I think about 4 hours in biometry event. And so, Eric, please share the QR code if you want to register. It'll be free. Remember, the discussion will be in Portuguese, okay? The lectures, the international speakers will be in English. So part of the lectures you can understand, like Yamani, Kalevali, David Chang, but the discussion will be in Portuguese, okay? David, thanks, folks. David and Dr. Mei Shang are in the organizing the masterclass with me, and thanks for your effort. And I hope you can with more cataract masterclass. Thank you, my friend.
No, my pleasure. Thank you for the opportunity, and see you in the next master classes.
See you.
Bye bye.